The monitors blared their urgent warning as Lanera's heart rate plummeted. VFib, I shouted, my voice piercing through the controlled chaos of the ICU. Start compressions. The ICU nurse launched herself over Lanera's chest, her hands interlocking over Lanera's sternum. As she started chest compressions, time seemed to slow, each second stretching like molasses. Lanera, just 42 years old, had been a medical enigma since arriving at our hospital just 2 days ago. Now she was slipping away, and we still didn't have the answers. Clear! The defibrillator whined as it charged. Once the shock was delivered, Lanera's body jolted as the electrical current surged through her. Miraculously, a rhythm returned. As the team stabilized Lanera, my mind raced back to her initial presentation, searching for clues we might have overlooked. 2 days earlier, Lanera had stumbled into our hospital when she came into the ER clutching her abdomen.
It feels like someone is trying to cleave me in half.
As I made my way down the hallway, getting closer to her room, finally entering her room, I could smell the ketones from her breath. A red flag that set my mental gears turning. Her vitals told a story of a body in crisis. Blood pressure was 95/70, heart rate was 126, respirations 22 breaths per minute. Her abdomen was exquisitely tender, especially in the epigastric region. My stethoscope felt cool against her feverish skin as I listened to her heart racing. Can you tell me about your medical history? I asked. Through gritted teeth, she managed to explain her long-standing battle with type 2 diabetes. I've been off my meds for a month, she admitted, shame coloring her words. Couldn't afford them. Her admission hung in the air, a stark reminder of the often invisible barriers to healthcare that many of our patients face. Her initial numbers were alarming. Blood glucose, 497. Urinary ketones, 4+. Serum ketones, 3.4. Her arterial blood gas showed metabolic acidosis with a pH of 7.25 and a bicarbonate of 12. The pieces of the puzzle were there, but they didn't quite fit together, like a jigsaw with pieces from different boxes mixed in. The main diagnosis was DKA, diabetic ketoacidosis, but oftentimes DKA is triggered by an underlying issue. And that nagged at me. It was like an itch in the back of my mind that I couldn't quite reach. The abdominal pain was too severe for typical DKA. It was as if Lanera's symptoms were shouting at us, but we were only hearing whispers. Let's get an abdominal CT scan and a lipase level, I ordered, my instincts screaming that we were missing something crucial. While we waited for those results, I spoke with Lanera's sister, Imani, who had arrived looking frightened and exhausted. Has Lanera complained of any other symptoms recently? Anything out of the ordinary? I asked. Imani shook her head, her braids swaying with movement.
Just the usual stuff with her diabetes. But
she hesitates, biting her lip.
She's been working 2 jobs, trying to save up for her meds. She's been so tired, eating whatever's cheap and quick, mostly fast food like Taco Bell, Chick-fil-A, and McDonald's.
I nodded, filing away this information. Poor diet, stress, lack of medication. It was a recipe for metabolic disaster, manifesting visually as diffuse pancreatic enlargement with irregular borders based on the CAT scan findings. Acute pancreatitis, I muttered, the diagnosis adding another layer of complexity to Lanera's case. It was like trying to solve a Rubik's Cube blindfolded. Each move made the overall picture more muddled. We initiated treatment for both DKA and acute pancreatitis. We're talking aggressive IV fluids, insulin drip, electrolyte replacement, and pain management. But as the hours ticked by, Lanera's condition continued to deteriorate. Her body a battleground where we seemed to be losing ground with each passing minute. Her lipase level, which had initially been 2,900, skyrocketed to 5,800. Her amylase followed suit, climbing to 1,902. Despite her best efforts, her metabolic acidosis worsened, with her pH dropping to 7.18 and her anion gap widening to 26. It was as if her blood had turned to acid, eating away at her from the inside. Oftentimes, pancreatitis is caused by drinking alcohol, but she adamantly denies drinking alcohol. Another common cause of pancreatitis, gallstones. But the ultrasound showed no evidence of cholelithiasis, effectively ruling out gallstone pancreatitis. Sometimes medications can cause pancreatitis, but she's not taking any medications. The medical resident, Dr. Goldstein, sarcastically states,
"Must be a scorpion sting,"
alluding to the fact that sometimes, although incredibly rare, a scorpion sting can lead to pancreatitis. We tried everything in our arsenal. We adjusted her insulin drip, increased her IV fluids to 250 mLs per hour, and even started her on broad-spectrum antibiotics as a precaution. Yet, her condition continued to spiral like a plane caught in an unrecoverable dive. Her kidney function began to deteriorate, with her creatinine rising from 1.0 to 1.8 in just 24 hours. Her liver enzymes were also climbing, with an ALT reaching 120 and an AST hitting 98. Lanera's triglyceride level was a staggering 2,670. It was as if someone had replaced her blood with liquid butter. In that moment, the pieces of the puzzle finally clicked into place. Hypertriglyceridemia-induced pancreatitis associated with DKA, diabetic ketoacidosis. That's the diagnosis, and it's the perfect storm for disaster. For me, it was time to use ADH. ADH has the processing power of thousands of medical studies and case reports all combined into one. I input Lanera's medical details into ADH, her initial symptoms, lab values, imaging results, and our failed treatment attempts. As the system processed the information, I found myself holding my breath as if I were waiting for a jury to return a verdict. Seconds later, ADH's response appeared on the screen. The recommendation hits me like a bolt of lightning. Of course, the insulin would not only address the DKA, but also help break down the triglycerides. Plasmapheresis could quickly clear the excess lipids from her blood, giving her pancreas a chance to recover. It was so simple, yet so easy to miss when caught up in the complexities of Lanera's presentation. We started plasmapheresis. The plasmapheresis machine hummed to life, its centrifuge spinning Lanera's blood, separating out the excess lipids like cream rising to the top of milk. Things began to improve. Her triglyceride levels dropped dramatically from 2,670 to 500 after just one session of plasmapheresis. Her lipase level decreased to 800, and her metabolic acidosis resolved with her pH normalizing to 7.38. And finally, after what had felt like an eternity, we were able to take out her breathing tube, meaning extubator, get her off the ventilator, and she was eventually discharged from the hospital. Do you have a question about this medical case? Just click on the link below.